Okay, so thank you for the invitation. It's my pleasure and my honor to share our IVL experience with you. And the challenge of treating severely calcified coronary lesions, including impairment of device delivery, which may result in procedural failure, and also requirement for high pressure, especially balloon or osteotomy device, which may cause procedural complications. The stent polymer damage and impaired drug delivery and suboptimal stent deployment, which are related to the TLF and the MACE rate. So the calcium modification technology, including traditional balloon, NC balloon, and ultra high pressure balloon, and especially balloon, scoring balloon, and cutting balloons. But those balloons may cause barrel trauma to the vessel wall. And the osteotomy device, including rotablator, orbital osteotomy, these devices are ablating the superficial calcium only, and the effect also depends on the wire bias. And the IVL is powered by the acoustic burst and the nut balloon dilatation to avoid the vessel wall injury and decrease the risk of arterial dissection. The mechanism of IVL for calcium is fracturing by acoustic energy. IVL modifies both superficial and deep calcium. The strategy to manage calcified lesion. The first route will be imagery assessment, including the CT scan and the coronary angiographic, and then intravascular image assessment, including the IVUS and the OCT. And there are different lesions, including uncrossable lesion, superficial, undeletable lesion, and the deep calcium. And for the tool selection, a rotablator can be used for uncrossable, superficial, undeletable lesions. And the orbital osteotomy also can be used for uncrossable, superficial, and undeletable lesion. And the laser can be used for uncrossable lesion. The IVL can be used for superficial, undeletable, and deep calcium. For the specialty balloon, ultra high pressure balloon, and cutting balloon can be used for superficial or undeletable lesion. So not all the calcium is the same. By using the IVUS and the OCT, you can see the deep calcium and the superficial calcium, concentric calcium, eccentric, and calcified nodules. So the IVL system can consist of generator, connector cable, and the caster. So the generator produces the electrical impulse to the lithotripsy emitters, and they creating the shock waves, which is a specific form of a solid pressure wave. Those pass safely to the soft tissue without injury, but they can create the fracture, superficial, and the deep calcium. And the pressure wave is equivalent to 50 atmosphere. They also can create the microfractures, which allow the circumferential stent expansion. This is the example from Disrupt the CAD3. This is a pre-procedure OCT. You can see 360 degrees of calcium, and this is the post-IVL. You can see the mud plane and the longitudinal calcium fracture, and this is the post-standing pictures. We can see the quite even expansion of the stent. So the IVL's mechanism of action versus traditional angioplastic. We know balloon only provide the compressive force. It creates a fracture at the weakest part of the calcium, but the IVL has a compression force, shearing stress, and a tensile stress. It can create large fractures and microfractures in multiple directions, perpendicular to each other. So it's very important to maximize the sonic output by reducing air in the balloon. Therefore, proper balloon prep is critical to ensure maximum sonic pressure reach the calcium. So for example, this figure, the yellow curve represent the air in the balloon, like the angiograph here, and it reduces the sonic amplitude by 20%, and also reduce the fractures by 40%. So the air prep is very important for IVL. So IVL is most effective in lesions with calcium arc larger than 180 degrees. It also effective in all spectrum of the calcium, like concentric, eccentric, or nodular calcification. For the concentric calcification, IVL fractures the calcium very quickly, usually within 10 to 20 pulses. For the eccentric calcification or calcified nodule, we need to deliver a lot more energy because most of the energy going to the normal vessel and dissipated. So we need a pulse management strategy to fracture concentric calcium, which will happen very quickly, and use the remaining of the pulses of the eccentric calcium or calcified nodule. So coronary IVL disrupt CAD clinical program, including disrupt CAD 1, 2, 3, 4, and the CAD pool. They enrolled 628 patients at the 72 sites. The paper are published at the JACC and the Circulation. And so the result disrupt CAD 1 to 4 and the pool study demonstrated the low 30-day MACE and low event rate, including any angiographic computation, and the flow limiting dissection, perforation, blood pressure, slow flow, no reflow, which are very low, and the procedural success rate is quite high. So for the difficulty in closing the lesion with IVL, we can try every tip and tricks used in the advanced PCI, such as the body wire technique, anchoring technique, or use guide steering caster, can overcome the deliverability issue. The 6-branch guide extension caster are compatible with all the diameters of C2 caster from 2.5 to 4 millimeter. If balloon can be closed, we can use balloon to do the pre-dilatation. If balloon fails closed, we can use osterectomy. This is a symbol, and this is a lesion at the mid-RCA. Rotor operation first, and NC balloon still undilatable, and the IVL can fully dilate the lesion, and this is after standing picture. Another important issue is IVL to the severely calcified left main lesion. The main concern is the need for blood vessel occlusion to deliver the required energy, which could lead to a severe ischemia. If hemodynamic changes may need a shorter balloon inflation to minimize the risk. So there are several considerations during the IVL of the left main artery, when there is LV systolic dysfunction, we may consider to use MCS support, and the level of anticoagulation is the same as the standard PCI procedure. The intravascular imaging is strongly recommended. The guide steering caster sometimes is needed to facilitate the IVL delivery in challenging anatomy lesions. So this is a example. You can see the distal left main, quite tight stenosis, and the lesion are also calcified. The RCA was quite okay. So we use a 1.25 bird just to create the channel for the IVL balloon can be closed. And this is 3.5 IVL to treat the left main proximal LAD. You can see the balloon at the left main gradually expanded. That means the lesion can be expanded. So the post the IVL, we use the stent to we do the stenting, 2 stents overlap, and this final angiography results. And this I think the angiography result is quite good. Because the time limitation, I will speed up the imaging. You can see the stent expand quite nicely. Yeah. So for the nodular calcification, it also we have some tips. So they use the intracoronary imaging to assist the guide bias and to assist the calcium modification device selection. For the orbital osterectomy, often requires slow device motion and higher speed. To improve the rotational osterectomy bird contact with the calcified nodule, consider upsizing the bird to arterial ratio to 0.6 to 0.7. And if there is an unfavorable guide wire bias, or consider using the rotor wire extra support to change the guide wire bias as needed. So for IVL, probably for the nodular calcification lesion, we need more pulses to treat the lesion. After the IVL, we can perform the one-to-one NC balloon dilatation just to check the lesion if the lesion can be dilated. So this is an example. This is 66 male acute coronary syndrome, dystrial CAD post PCI and stenting. from the angiograph, we can see there's a quite tight lesion at the mid RCA just between the two stents. So we used 2.2 millimeter NC balloon to dilate the lesion first, and then do the OCT. This is the OCT imaging. And we can see the calcified nodule. And this is eruptive calcified nodule. I think this is related to the patient clinical presentation acute Crohn's syndrome. And after OCT evaluation, we use IVL 3.5 by 12. And after IVL treatment, the lesion is still quite tight. And then do the OCT again. But we can see the lesion was not adequately dilated by the IVL balloon only. So we use a cutting balloon. This is 3.5 by 10 at 20 atmosphere. And OCT showed that the lesion can be further dilated, but it's still not perfect expansion. However, we use DES to the distal RCA, and this is DES 40 by 15 at the mid portion of the RCA, and to overlap with the two stents. So this is the final angiographic result. I think the MSA minimal stent area was 7.97. It is quite enough. Yeah. However, the patient developed angina a year later. The TET showed strong positive, and we did angiography again. You can see there's a severe in-stent restenosis at the mid portion of the RCA, which was calcified nodule. So this is quite severe stent ISR. So we did the OCT again, which showed there's quite severe neo-atherosclerosis, a lot of calcium in the stent. So we performed the 2.0 BER to do the operation to ablate the calcium in the stent. And after the 2.0 BER, and we use a 4.0 NC balloon to do the balloon dilatation, and this is the result after 4.0 NC balloon dilatation. And then we do the OCT. We can see that we created some lumen by the 2.0 BER, but there's quite a lot of tissue still in the stent. Therefore, we use 2.25, and then we can see the lumen is further. The bigger the lumen is bigger. We believe also we operate some part of the stent strut. And after that, we perform, after 2.25, we use 4.0 IVL to treat the lesion again. And this after 4 IVL, we use NC balloon and also use DCB to treat the lesion. And last, we use a DS to cover the lesion. This is the final results. You see the stent expansion quite nicely. Yeah. And this is the second case, the 85-year-old female. He received the TAVR on April 2024. Heart failure admission, poor renal function. So we use the Jenkins 3.5 8 French, and to do the PCI for the left main osteo left main calcified lesion. You can see there's a haziness as the osteo left main. And so you can see from the OCT, you can see the very calcified as the left main ostium. Sorry, because the time I'll speed it up. This is 1.75 BER, and to break the left main ostium. And then we use 2.25 to break the osteo left main. And this procedure was supported by the ECMO. And because the poor renal function, we use 10% dextrose to guide our procedure. And we can see by the 2.25 BER can create a larger lumen. So after that, we use IVL, and then Megatron, DES, and then NC balloon post-dilatation 4.5. So this is final angiography results. the standing results confirmed by the OCT. So my conclusion is IVL is a highly effective tool in managing the patients with moderately to severely calcified coronary lesions with a short learning curve and a favorable clinical outcome. Osteotomy before IVL rotatripsy or orbitotripsy may be needed in some specific lesions. From our experience, there are still challenges in patients with calcified nodule and stent under expansion, although it's off-label use. And larger prospective studies are needed to provide the treatment strategy of IVL in facilitating stent expansion in the setting of different lesion characteristics. And thank you for your attention.
Thank you, Dr. Chao, for your excellent lecture and sharing your experience. Dr. Chao will leave online after short discussion. So we have the eminent panel, Dr. 강인숙, 김병호, 사영경, 양인호, 장우진, 허성호. Feel free to ask question to Dr. Chao. Dr. Chao,
Yes.
Actually, I have a patient, the ostial RCA, highly eccentric calcified stenosis. The lumen is highly stenotic, only the 1.5 balloon can cross. After several attempts of ballooning, the balloon always rupture. So we stopped the procedure. Next time, the half of nearly 2/3 of lumen occupied by calcification, just one side normal appearance. In that case, the node aberration and lithotripsy balloon is okay. So the other 1/3 is just normal vessel looking. So I worry about the application of lithotripsy balloon may damage the vessel or sometimes rupture the normal side. So do you have opinion or experience in this kind of region?
Yes, we have some experience of the osteo lesions, like Lehmann osteo or osteo RCA lesion with heavily calcifying. And for this kind of lesion, if we do the osteotomy, we prefer to use sorry for that. We prefer to use atrial support wire, guide wire, nodal wire, and guided by the IVUS, and to check if the wire bias is okay. And if the wire bias is okay, then we can use nodal operator. The procedure can be quite safe. And once the lesion are operated by the rotor operation, then IVL balloon can pass easily. And the IVL balloon will not injury to the normal part of the vessel, because there's no harm to the flexible the normal vessels, and it only have an impact on the calcifying lesions. So if there's an eccentric lesion, we need more process, but it is quite safe. It's quite safe. It will not injury the normal part of the vessel.
Thank you.
I have a short question. And when considering the cost saving, which lesion or which case is necessary to both rotablation and IVL in the same patient?
Yes, this is a very good question. And normally, if our practice is if the device uncrossable, for example, the balloon cannot cross or image caster cannot cross, then we will use the rotatripsy. We normally use 1.5 millimeter rotor, but actually, if we use 1.25, if 1.25 per cross the lesion, then IVL balloon can also cross the lesion. So, so for us, the uncrossable lesion is our major indications for use rotatripsy. Yeah.
Do you have experience of applying lithotripsy balloon to the peripheral artery?
Yes, we also have the IVL to treat the peripheral vascular disease. Yeah, and because I don't do the peripheral intervention, but we have the process is more. I think it's about 300 process, and the emitters is more. It's more than the coronary IVL balloon. Yeah.
It's it may be not polite, but how much do the cost for the use of lithotripsy balloon in your country?
Sorry,
How much does it cost for one lithotripsy balloon?
The cost do you pay?
Okay.
Yeah.
In
Is
Taiwan,
reimbursed?
it is yeah, it is expensive. It's about $6,000 US per IV balloon.
Oh,
Yeah,
$6,000.
yeah.
Not reimbursed now.
It is not reimbursement. The patient has to pay by themselves. Yeah.
Okay.
So it's not actually it's not all the patient can be treated by the IV balloon. But however, IV balloon is safe and quite effective for the chest ventilation.
혹시 허성원 선생님도
Thank you for your nice lecture. Actually, I have no experience about the lithotripsy balloon, so I have not much knowledge. But lithotripsy balloon maybe not easily pass the tight lesion, so there are some rule for the predilation. If I performed predilation, I worried about some dissection. If some dissection happened, I can safely use this kind of lithotripsy balloon.
Yes, if the dissection is less than type C, we can use IVL balloon safely. But if the dissection severity is more than D, and I think it's a pretty concern about the vessel injury. So most of the case we can use IVL even after the balloon pre-dilatation, or even with some dissections. Yeah.
Thank you, Dr. Chao. It's time to close your lecture and discussion.
Thank you.
In